Hello and welcome to lecture M6.3, Information and Communication in Healthcare 2. This lecture applies to students in Dublin, Bahrain and Penang, although students in Dublin have received a slightly different version due to timetable changes. The learning outcomes for this lecture are as follows. To understand the definition of the term medical informatics, to understand the basic components of a database, to understand the basic components of a patient record, and to understand the international classification, statistical classification of diseases and related health problems, otherwise known as ICD-10. There are a couple of files associated with this lecture. The first is a very straightforward and very short video, only 6 minutes long, on YouTube, giving you a definition of what is healthcare informatics. This is very important, this definition. This is quite a broad subject. People devote their whole lives to it, and we can only take one slice of it. But this basic definition is good and useful in this context. So I want you to think of information and the fact that it's all around you. Here we are looking down on this building in St Stephen's Green in Dublin, the Royal College of Surgeons. We can find these places very easily. We could even look into the Chief Executive's office. There is the clock on the wall in his office. This is fairly frightening stuff when you think about it too much. Similarly, here are some pictures of Bahrain, taken in a different time frame when the university was, as you can see, there's been more building around it, different resolution of the image, so this information has been updated all the time. And here's a picture of the college in Penang, so nobody feels left out. So we're in a situation where there is so much data and its volume is increasing on a minute-by-minute basis. Take a look at this curve, starting at 2005 and going up to about 2011 and beyond. And it's talking about the amount of digital information created each year. Billions of gigabytes. We're going exponentially upwards. The amount of emails sent per day is increasing, tweets, photos and videos shared. All content is booming. This is a very interesting statistic. 80% of all US adults whose location is known via their mobile phone. And that is certainly a compliment, if you like, of the modern age, that our phones can track our location minute by minute, and we are rarely without the phone. So, in that context, I've taken a very simple term, patient use internet. I've not patient use of the internet, just patient use internet. Those three words, and here are the results from 2013 and the results from late September 2014. And in that short time, users have gone up from 75, or hits have gone from 75 million to 91 million. And to a degree, we look at this number and it's pretty meaningless to us. We rely on Google to give us the information that's right at the top. And indeed, in this case, it is the same article that is on top when we type in patient use internet. What's changed maybe by it is that it is cited or referred to by other articles online. We'll get back to that in a minute. But a huge increase in actual hits over 1 year. Similarly, I've gone to Google Scholar. We can see patient use internet in 2013 gave us 1.5 million results and 2.28 million results 1 year later. And again, the same hits are coming up, the same information, but with a huge user base or information base beneath it. And then I've used the PubMed service, which we'll talk about further, to query those three Patient use of internet, are slightly different here, that's my mistake, but PubMed will not make the difference, and we can see in 2013 there were 16,000 articles related to this and 18,500 articles related. Now the issue we have, of course, is that PubMed gives us very good results, but how can we possibly stay on top of all this information? And of course we can't. That is one of the biggest challenges we face. There's so much new information, we can't keep on top of it all. And this is a problem of the modern age. So there is a PDF in Moodle for reference. I'm not asking students to read it slavishly, but you must understand the basic concepts. Health literacy, health information seeking behaviours, and internet use amongst patients attending a private and public clinic in the same geographical area. So I'd like you to get an idea of what the authors have done. This is in July of last year. It says, as healthcare enters the digital age, healthcare providers must recognise the importance of face-to-face physician encounter. Wow, how simple is that? Make sure you talk to each other. But some of the issues covered here are quite important. The amount of data bombarding people, and indeed private and public patients. These are people from different socioeconomic backgrounds and therefore will not have access to the same level of technology, and it follows information. One other search I did that was from 2013 and this from 2014 is Twitter use. And you can see there were 21,000 articles there and 23,000 articles there. So it even is suggesting that maybe we need to go back to internet patient use. But there you go. You see, all of this thing is growing, and you know that Twitter is growing. If we take it in the context of the medical record, there was, as you may be aware, a time where all information was stored centrally. It was paper-based or film-based or whatever the actual physical medium was. We relied on individuals to fish the right information out and hand it to us. Then, of course, we had to hand it back. Hospital records became more efficient, maybe filed more correctly. This is a very neat-looking system. Somebody still has to file this information, and once it's taken out to be used, it is essentially out of the mix and cannot be reused until it's put back. We have developed somewhat in the last 10 years to electronic healthcare records, and now the latest wave of innovation is around tablet PCs and their use for harvesting patient data. And there is a huge area associated with this around privacy, security, and so on. But we're heading to the mobile age, or we're in the mobile age, so if the information is current, it's got to be in your hand and ready to go. Students may like to follow this link just to get an idea of the complexity of information that's available. And whereas you may be looking up anatomical drawings, and this is a Google product, the Biodigital Human, there is a fee to it which you need not pay. There's a premium level, but you can log in if you have a Gmail account or a Google account, and allied with that, you can take a look around. This is absolutely fantastic. There's pricing, but as I say, there is no need to subscribe to this service for the level that you're going to need it. But it's certainly a very interesting distraction. So let's get back to that reference of the definition of medical informatics. So it's a little boring and wordy, but we need to find a basic definition so we know where we're going. And let's talk it in medical informatics. We develop and assess methods and systems for the acquisition, processing, interpretation of patient data with the help of knowledge that is obtained in scientific research. So medical informatics, acquisition, processing, interpretation of patient data. Getting, doing something with, and understanding patient data. And this has many uses, but most, if we put them into three broad areas, informatics can help us with research. How many people have had a hip replacement and then went on to have some adverse reaction? If we can capture that information, we can do some keen research. It can obviously help us to care for the patient and also to educate healthcare professionals in that field. In terms, and this is very basic stuff, but nonetheless important when we're looking at structuring information, to process information, we need to get it into a computer. And we can take this for granted in that a lot of information is freely available to us. We just look it up and read it, but somebody's had to type that or scan it or wherever it may be. And getting that, processing that data is vastly important. Think of it from the point of view of scanning blood results. The output from a machine that's measuring blood glucose needs to be captured, needs to be assigned to a patient number, needs to be assigned to the correct patient. We need to be able to look after this data, make sense of it, and then reproduce it elsewhere. And of course, in that, we need some kind of networking, telecommunication, and integration of systems. So it really isn't just a matter of looking something up. Where did the information come from? Is it reliable? And can we send it around a network? So here's something that you can try. We're going to cast our minds into the future where you have graduated and you're working hard in your respective clinic and you are a family physician. Let's assume that you're a family physician. So that's what we would term general practice. And for the purposes of this lecture, I want to change that, my mistake. A girl and our parents attend your clinic. And the parents are new to the area. They've just moved in. You've had no record of them whatsoever. You don't know who they are. You don't know where they've come from. You don't know anything about them. Your clinic is full and you're tired. The working life. This is the reality. So there's your patient. This is Grace Clarke. She likes to wear those glasses. I don't know where she found them, but she thinks they're funny, and I think they are a little bit. So that's Grace. Here she is. She looks like a normal 9-year-old girl, happy, adjusted, we hope, but you don't know anything about her. So the question is, what can you find out about her? Well, you'll know that's her name, Grace. She's 9. But what's the issue? The parents say they have to shout at her, and they think she may be going deaf. Now, that's a big, big problem for a parent. Something's wrong with their child. They're very, very anxious. They're worried. They're going to think of the worst. And the parents also tell you that Grace's teachers have noticed a problem. That's all you're hearing. There's something wrong here, but there's no other information. The parents have just said, there's a problem. We don't know what it is. We're worried. Help us, doctor. So, what do you write down? What do you record? What questions do you ask? That's a fairly difficult and big ask for you, but think about that. So I'd ask you to just stop the video here and list 10 pieces of data. Anything at all. Stop it and write them down. And then restart the video and pick it up. So do that now. Stop the video. Okay, so we're back. I hope you've done that because the first time I did this exercise, I was very surprised. I was thinking about all sorts of things. And, one of the things is name. But what is her name? Grace Clarke? Is it Grace Margaret Clarke? You may have 2 Grace Clarkes. You need to make sure you know the difference. You need to record the address where they live because it's a new record, their age, her gender. It doesn't matter. You need to absolutely have to height and weight. They're important. Do you have time to record those now? But they are important for developmental issues. Children should be within a certain index. What are the parents' names? What are their address or addresses? They may live separately. Phone numbers. Then we could ask almost anything, but it's all still relevant. Do they smoke? What do they do for a living? Where do they work? Are there any allergies in the family? Are they insured? Is that important in the practice you're working in? Blood type. What are the chances of 2 parents knowing their daughter's blood type? Have they been to any other clinics or hospitals? When did they go? What was the issue? And what current medication? Now, these are 20 pieces of information. And there's some very obvious ones we haven't even begun to ask. So obviously this is vastly complex, and we can't let that information, all of this information, get in the way of treating Grace and finding out what's wrong with her and helping her and her parents get back to normal and lead their lives as they would like to. And rather boringly, and this is unfortunately the way data works, if we're taking somebody's title as Mr., Mrs., Miss, Infant, gender, male, female, information needs to be broken up. Status, are they married, single, divorced? Well, maybe you think that wouldn't matter. Well, it's going to be a database field, maybe. Maybe it isn't. Depends on what you're filling out. Have they had another doctor? Where is that doctor? Do you need to get in touch and get those notes from the hospital or the other clinic? And you can see very quickly something very straightforward, we hope, becomes very complex. So there could be other data that you're getting. The actual description of what's wrong with Grace is something called glue ear, which is a blockage of the eustachian tube here, which causes the eardrum, the tympanic membrane, to become rigid with a loss of hearing. And the remedy in extreme cases is to put a little, like a tap almost, in the eardrum to let the fluid leak. It's called a grommet. It's very common, and the biggest cause of earache and ear infection in children is usually, they can be diagnosed around that as well. If you had an otoscope, if you were to stick something in the child's ear, you might want to take a picture. Where do you put that picture? Does it go into a medical record? Is it just enough for you to look at it? Do you draw a picture of what you've seen? So forth, so on. You can see this can become very, very, very complex. So, whatever about the diagnosis, here's another aspect to what has happened here. How do you define what Grace Clarke has been diagnosed with? This glue ear is very easy to spot, but what is it? If you look at definitions, medical definitions, there's many, many types of it. For example, here are 3: otitis media with effusion, secretory otitis media, chronic secretory otitis media. And what this tells us is we need to classify and code. And it is a big challenge to be consistent in this area, because there are different types of glue ear, different types of severity, and we need to be clear on which one we're dealing with. And to do that, we use something called the International Classification of Diseases and Health-Related Problems, abbreviated to ICD-10. And this gives us detailed descriptions of diseases and or injuries. And every disease is described with its diagnosis and a unique code. This information is freely available here. Go take a look. It's quite a lot of information. Just get a feel for what's going on. You can see there's many different types of classifications. It is organized by the World Health Organization, and it is used extensively around the world. And it is used by most countries to define morbidity, the instances of death, so how many people died of, and what was the cause of death. So these statistics are published pretty much in every country in the world, because a lot of health policy is determined by this. Also, hospitals would define the numbers of patients seen with X or Y condition. Pretty important when it comes to organising resources, people, training, equipment. They need to know what's going on. So it gives us a comparability internationally for the collection, processing, classification and presentation of statistics. It also helps with automated decision support, but these are different types of systems. So let's dig in a little bit here. We've got ICD-10, it's the current version, revised in 2010, and we look diseases of the middle ear and mastoid. There we go, age 60 to age 95, and we can drill down even further. We've got age 60 to age 95, diseases of the external, middle, inner, and disorders of the ear. And we can go down even further if we wished. So you're not supposed to know these codes. They would be applied by a computer system or people who code in administrative departments in bigger hospitals. But you can see even down this side, diseases of the nervous system, eye, ear, circulatory, and so forth and so on. There is a vast range of classification. So if we go back to Grace, we think her patient record could be very, very complicated very, very quickly. It will have a lot of data. Every time Grace visits you, there will be more information to gather. Even if you issue a prescription for medication, what day she visited, any notes you take, everything has to be recorded and accessible thereafter. You have to be able to get the patient's notes to refer to them, to know that the patient has been there before. All of this information has to be reliable so you can read it. Scribbling it on a piece of paper would not be much help if your colleague needed to read it, or indeed you went back to it 3 months later and there was no structure to the data. And obviously it needs to be kept safe and secure because you have a duty of care, a moral and ethical responsibility to that patient to keep the information. And above all, it can't get away in the way of the treatment. That is, the patient record and taking the information is not where your focus should be. Your focus should be on the patient. So it's a difficult job to juggle. Now, there is a link on the course page to an old YouTube video, but it's one that was recorded by a colleague of mine who has worked in the Department of Obstetrics at the Royal College of Surgeons. And it's called Taking a Patient History. It's a short video, but very, very important. And you're not expected to know all the details of the presentation, but you should be able to answer the questions that are asked by the lecturer. Dr. McVeigh is a practicing obstetrician currently in Toronto, and he goes through the types of information you would be expected to collect when talking to a patient. So just look at that video in the context of how Dr. McVeigh explained, a practicing physician. Now, a little more technically now, in a hospital setting, there are many users. It's not just you sitting at a desk or you standing at a bedside. There would be obviously nurses, lab technicians. And with more people, there comes the chance of more user error. And how might that be limited? Well, there are so many ways to do that. And that is for another day. So systems need to be designed sufficiently so that user error isn't an issue. Remember, of course, that information comes from multiple entry points, so x-rays, ultrasounds, lab results, admissions, billing, all that kind of thing. It's not just one person taking the information at a bed or at a desk. There's lots of people taking the information, contributing to this one patient record. And this record needs to be viewed anywhere and at any time. It needs to be accessible. And here's a schema just looking at that. There is the patient database, if you like, sitting in the middle. These are all the inputs we could have, supplies, whether the patient is, for example, using a lot of bandages or whatever it may be. What are the theatre resources, imaging taken, drugs given to the patient, tissue sampling. All that information needs to be coded and assigned to the patient. There is the coding of the disease, and there also financial reporting and clinical support systems. There is a vast amount of data going in and out, and as a practicing physician, hospital doctor, you may not see or be aware of all the complex transactions that are going on. You just want to be able to call up a screen and find out what's going on, or know if the blood results have come back and that kind of thing. So to review, medical data is highly complex and comes in many different forms. Numbers, text, images, sounds in the case of some ultrasound. But the data has to be structured in some way so it becomes useful. It should not be just taken as an exercise. Oh, we need to fill out this form. the form should do some good. It should be put to work. It should be processed and interpreted somehow. And you really have to ask yourself, do you have the time to do this? What's going on here? How can I make this more efficient? And as you go on through your careers, and if you're involved in this kind of process, the cost becomes a huge factor. And we'll get back to that in another lecture, because these projects can literally eat money and it disappears very quickly. And overall, with this, if the system isn't safe, there's a problem. We must protect the patient's confidentiality. So in short, data is everywhere, it must be organised, and it must be described, and it must have integrity. It will come from all sorts of places towards us. What do we do when we see this data? How do we interact with it? We must reorganise it and describe it, put it into some kind of context. And of course, when we do that, we must maintain some kind of integrity. So thank you for your time.